welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Hi everyone, thank you so much for attending. My name is Shania and I'm excited to give this presentation. So these are some abbreviations that I'll be using throughout the presentation, and the learning objectives for today are to first recall prior literature and guidance regarding the interaction between parenteral, olanzapine, and parenteral benzodiazepines. Secondly, to assess the study by Kroll and colleagues for significance and power. And lastly, to evaluate the safety of co-administration of parenteral olanzapine and parenteral benzodiazepines, considering the study by Kroll and colleagues. So to go over some background on why this is important to talk about, a quick review of agitation in the emergency department. The majority of agitation in the emergency department is attributed to alcohol use, and this is significant when considering that the risk of concurrent parenteral olanzapine and benzodiazepines is thought to be higher in alcohol-intoxicated patients. Agitation is a medical emergency necessary to treat with parenteral agents due to the complications associated with delays in medical care, medical complications associated with excited delirium, workplace violence, as well as consumption of healthcare resources. As a review, the place in therapy for the agents of conversation today per the Project Beta 2020 guidance is for severe agitation in conjunction with restraints and comprehensive diagnostic testing. When looking at the pharmacokinetics of the agents in question, parenteral, olanzapine, and benzodiazepines share similar onset and time to peak, which is theorized to contribute to its synergistic adverse effects seen in the earlier literature. Additionally, IM olanzapine achieves a 5 times higher peak concentration compared to its oral counterpart, also thought to contribute to this cardiorespiratory depression. It also has alpha antagonism, which differentiates it from other first-generation antipsychotics, and is also thought to contribute to synergistic hypotension with concurrent parenteral benzodiazepines. Both the FDA and the European Medicines Agency contain warnings about this interaction in the olanzapine package insert. The FDA notes not recommending the administration of the two due to potential for excessive sedation and cardiorespiratory depression, while the European Medicines Agency suggests separating them by at least 1 hour or considering the co-administration after a risk-benefit conversation and assurance of close monitoring. Though this interaction is in the package insert, the evidence behind this warning is based on a safety database search and small retrospective studies. So first, Martyr and colleagues found a majority of adverse drug reactions reported were concomitant with benzodiazepines and some fatalities associated with polypharmacy and older age, but this is limited by being based off of cases that were reported and cannot establish correlation. Wilson and colleagues published several retrospective chart reviews looking at the receipt of olanzapine in the ED, showing larger decreases in oxygen saturation in patients who concurrently received benzodiazepines and alcohol-positive patients, and found a significant difference compared to IM haloperidol, but these reviews are limited by the small sample size and retrospective nature. So the weakness of the evidence makes the validity of the concern questionable. Other newer literature contradicts the danger of this interaction. So first, Chan and colleagues conducted an efficacy RCT with olanzapine and benzodiazepine as one arm and observed no difference in cardiorespiratory depression outcomes compared to the other arms. Martel and colleagues conducted a retrospective chart review on IV olanzapine, and none of the intubations were concurrently administered with benzodiazepines. Lastly, Williams published an MUE looking at concomitant olanzapine and lorazepam use and found no instances of vital sign changes. This newer literature has its own limitations as well, but with a larger patient sample than the previous evidence, it compellingly questions the danger of this interaction. The American College of Emergency Physicians notably featured use of a Parenteral atypical antipsychotic in combination with midazolam as a treatment option for severe agitation in the emergency department in their clinical policy published in 2023. Note their recommendations do not apply in the out-of-hospital setting and patients over 65 years of age. So given that clinical policy conflicts with package labeling along with the wide variation in research findings, these both set the context for the relevance of this article by Kroll and colleagues. This article was published electronically in June of 2024 in the Annals of Emergency Medicine and on paper in December of 2024. The objective of the study was to compare rates of tracheal intubation in ED patients who received IM or IV olanzapine co-administered with either a second parenteral dose of olanzapine or benzodiazepines. This study was designed to prioritize the analysis of clinical outcomes for patients rather than the surrogate outcomes of vital sign changes that characterized the previous studies. The design was a single-center retrospective cohort study at a level 1 adult and pediatric trauma center at a safety net hospital in a metropolitan area. They also note featuring EMR and guidance documents at the specific institution for olanzapine, having a warning that says do not give within 1 hour of injectable benzodiazepines. Strengths of this design include being conducted at a generalizable hospital with warnings many institutions likely have, which mimics real-life settings with its cohort design. Some limitations include its inability to determine causation due to the retrospective nature, generalizability beyond the single center, and selection bias associated with the intervention arm being administered by providers disregarding the EMR warning, whether by mistake or by a risk-benefit decision. For the patient population, the inclusion criteria includes those 14 years of age or older, receiving one of the following regimens within 60 minutes of each other, olanzapine, or olanzapine benzodiazepine. By including only administrations within 60 minutes of each other, this study addresses the variance in timing in previous literature while capturing the timeframe of concern given the pharmacokinetics of the agents that I talked about earlier. Having a benzodiazepine group would have optimized the comparison of the regimen, but overall, I thought the inclusion was properly set up. The exclusion criteria included receipt of droperidol, haloperidol, ziprasidone, or ketamine in the ED, receipt of more than 2 total doses of olanzapine, or receipt of olanzapine and more than 1 dose of benzodiazepine. This exclusion criteria addresses some of the weakness of the previous literature of co-administered antipsychotic medications and dose stacking being confounders behind the cardiorespiratory depression. However, limitations of these exclusions include potentially excluding refractory agitation, only excluding antipsychotics rather than other sedating agents, and not accounting for the confounder of too high of a dose. The primary outcome of this study aligns with the primary objective of the study, which was looking at tracheal intubation. This could be captured during the emergency department visit anytime after administration of the medications of interest. The secondary outcomes were hypoxemia and hypertension, again, during the emergency department visit after administration of the medications, as well as death, which could be captured anytime during the hospitalization, regardless of medication administration. Limitations of these outcomes include only looking at negative outcomes rather than also positive outcomes, and the variation in time frame these events could have had rather than only observing within the time of concern after co-administration. Looking at only negative outcomes, however, does make sense for the question, as we do know that multimodal regimens are more effective for severe agitation, and the question is the safety of the practice we are currently not doing rather than the efficacy. For a statistical analysis, Kroll and colleagues used both descriptive statistics or analysis of between group differences as applicable. Variables were extracted directly from the EMR without human review. This allows for the most objective data analysis, but this also may not have allowed for quality review and assessment for documentation error or clinical caveats. They also conducted a subgroup analysis for patients with detectable alcohol concentrations, and this is significant because the previous literature that Wilson and colleagues published found a difference in hypoxia for alcohol intoxicated patients. And so a strength of the study is that it was addressing this question that came up. The study estimated to detect a 5% absolute difference with 80% power. They assumed that 2% of patients in the monotherapy arm would undergo tracheal intubation, and they also estimated that the combination arm would be 3 times smaller than the monotherapy arm. And so they estimated needing 585 patients in the monotherapy arm and 195 patients in the combination arm. They also ended up expanding exclusion criteria to 2 doses within 120 minutes to meet the sensitivity analysis. Now that I've discussed the intentions of the study, I will dive into what results were found. So the study was slightly underpowered with only 89% of the patients, the estimated needing to achieve 80% power. Between group differences in baseline characteristics were not assessed. To highlight some important differences between the two groups, less patients in the combination therapy group were alcohol positive, and this does make sense because you would avoid benzodiazepines in alcohol intoxicated patients. However, this would increase the risk of type 1 error because alcohol positivity would increase risk of cardiorespiratory depression. Both groups did have a similar level of alcohol toxicity, and also more patients in the combination group had a diagnosis of alcohol or drug intoxication or altered mental status, which is important because concomitant substance intoxication would be a higher risk of vital sign abnormalities. So the median time between doses was 29 to 30 minutes. So administrations were truly within 60 minutes as the study had intended, which is a strength. A very low proportion of these agents were administered within 2 minutes. So the results are not necessarily generalizable to true co-administration. 38% of patients received olanzapine as the first medication, while the rest received benzodiazepines as the first medication. The doses of olanzapine between the two groups were similar. Also to highlight, the majority of administrations were intramuscular, which makes sense for a population where IV access can be difficult to obtain, but this also means that the results may not be generalizable to IV administrations. So to look at the outcomes of this study, there was no difference in tracheal intubations between the two groups. Moreover, there were a numerically higher number of intubations in the monotherapy group at 4% versus 3%. To look at the reasons for intubation, a higher proportion of intubations in the combination group compared to the monotherapy group were due to respiratory depression at 80% versus 48%. Notably, none of the intubations in the combination group were due to persistent agitation, compared to 48% in the monotherapy group, which aligns with our knowledge that multimodal therapy is superior to monotherapy of severe agitation. A higher proportion of intubations in the combination group were also due to concomitant medical illness compared to the monotherapy group at 20% versus 5%. And when looking at the intubations within 60 minutes of second medication administration, the majority of them were within that 60-minute time frame, which strengthens the validity of the outcome by being temporally associated with the medication administration. There were also a numerically higher number of intubations in the combination group in the alcohol positive subgroup at 6.4% versus 3.6%. Lastly, when looking at the secondary outcomes, there were no difference in hypoxemia, hypotension, or death during hospitalization between the two groups. So this study included clinical narratives for all the intubation cases due to respiratory depression and the one death that occurred. Note that the paraphrases were created by me, so they should be interpreted with caution, and you can read about each case in the supplementary file. A limitation that I found with this study is that they did not separate the intubations by possibly and or likely due to olanzapine administration, and therefore they put the onus on the reader, such as myself, to read the supplemental and form their own conclusion about whether these intubations could be attributed to the regimen. So that's something to highlight. The sensitivity analysis expanded the administration time to within 120 minutes, and this expanded the population to include 1,038 patients. and they also did not find a difference in primary and secondary outcomes. So, to go over the discussion that the article highlighted, some strengths that the authors thought included the generalizability of the findings to a high-risk population of drug and alcohol intoxication due to the high incidence, alignment with a more recent literature, such as the Chan and colleagues RCT in 2013, and it also supports the ACEP policy that parenteral atypical antipsychotics can be administered with parenteral midazolam. They highlight the limitations of the study, including being underpowered, especially when looking at the alcohol-positive subgroup, inability to generalize findings to non-intoxicated patients, such as psychotic delirium, and you also cannot extrapolate the findings to true simultaneous co-administration, which may be useful in cases of severe agitation where we would be using this combination therapy therapeutically. So the author's conclusion was that administration of parenteral olanzapine and parenteral benzodiazepines within 60 minutes was not associated with an increased rate of tracheal intubations compared to 2 doses of parenteral olanzapine. So some of the clinical implications of the study, to circle back to the limitation that the authors noted a small between group difference leading to an underpowered study, I've highlighted the intubation rates reported in the currently available literature, which ranges from 0 to 1.3%. Kroll and colleagues anticipated a 2% rate of intubation, but other studies have shown much lower rates of intubation with both benzodiazepines alone and olanzapine alone. So the study would have likely been underpowered regardless if they had met their sample size because of the overestimation of intubation rates that they made based on the historical data, and therefore likely would have had a small between group difference anyways. I want to highlight a very similar study that came out very shortly after Kroll and colleagues was published. Lobb and colleagues published a retrospective chart review, but they only looked at patients who had received combination therapy rather than having a comparator monotherapy group for a composite of cardiac or respiratory compromise within 2 hours. Of patients who received combination therapy, 12.5% of patients had experienced the primary outcome, and they noted a trend towards a shorter time between administration in patients meeting the primary outcome. The limitations of this study include a lack of a comparator group and a small sample size. To add some of the additional thoughts that I have, I appreciate the study's focus on clinical outcomes as it is difficult to make practice changes solely based on surrogate outcomes, as has been done up until this point. Some questions that remain for me that I would like to be addressed in future studies include the safety in alcohol intoxicated patients, as well as psychogenic agitation, as both of these populations in the study were underrepresented, as well as a primary outcome that may be more helpful to look at for future studies, maybe new or increased risk need for supplemental oxygen as a primary outcome. The prevalence of intubation in the setting is too low to produce an adequately powered study, as was shown in this trial, as well as previous literature. And also, intubation is a drastic adverse event that does not capture our goal of doing minimal or no harm to the patient. So maybe something that I would do in a future study is looking at new or increased need for supplemental oxygen instead. Other variables also to consider looking at that were not captured by the study include dose correlation, if higher doses have any effect on this outcome, as well as true co-administration, as the next step could be to assess for feasibility of intentional combination therapy in the severely agitated patient, where because these EMR warnings exist, it's likely that combination therapy is in the literature thus far has been administered either mistakenly or after a heavy risk-benefit conversation with the provider team. So my takeaway from this article by Kroll and colleagues is that this supplements my existing perspective that the warning behind the co-administration of parenteral benzodiazepines and olanzapine was not justified by the evidence then and continues to not be supported by more recent evidence. As I mentioned previously, the study is an important step by introducing clinical outcomes that better support a practice change and label changes. I want to thank my preceptors, Joanne Smith and Amelia Nelson, for their help with this content. And that concludes my presentation. Thank you so much for joining, and I'm happy to answer any questions that you have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.